Please welcome our next presenter, as Research Director at the Institute for the Future Health Program, Rachel Maguire.
Hi, everyone. Good morning. As John mentioned, my name is Rachel Maguire. I'm a Research Director at an independent not-for-profit called Institute for the Future. I better say this right off the bat. If anyone is like, oh, great, a futurist, if you're looking for lottery numbers, if you're trying to find out if your daughter's going to get into Harvard in the next 10 years, I'm sorry to disappoint. That's not the work that we do. The work we do, in fact, is actually all about the present. For the last 47 years, the Institute for the Future has been working with groups and organizations to help them systematically think about the future so that we make better decisions in the present. It's our estimation that if you consider a wider and more diverse range of not just trends, but also drivers, disruptions, and discontinuities, then you'll make more informed and more meaningful decisions in the present. I've been doing this work for about 10 years, and one of the observations I can make at this point is to say that we're not collectively very good at futures work. It's hard to think creatively about the future, and it turns out that there might be some good reason for this. It may just be that we're wired to think about the future by thinking about the past. Neuroimages have shown that when people are asked to think about the present, if they're asked to think about the past and they're asked to think about the future, the same parts of our brains are activated. Now, there may be a really good reason for this. From an evolutionary perspective, it's good to have some past experiences inform our future movements. But when we're relying on the past to inform our future, it makes it that much more difficult to take seriously really transformative futures. And the first thing I can say about futures work, kind of the most critical first step, I suppose, is to recognize that there's different types of change. There's the kind of change that you can recognize by studying past practices and past behaviors. You can look at large historical data sets, extrapolate forward, and be able to derive some interesting insights about future expectations. This is really important work, especially if you're doing demographic trends, or you're trying to understand the future prevalence of a certain disease. But some of the tools, some of the cultural practices, some of the cultural norms, some of the policy changes, they're more difficult to recognize on a trend line. We often think of these types of change as disruptive forces, forces that are very difficult to identify if you're paying attention to historical data sets. I like that conversation in the earlier session about where's the data and how can you show evidence when you're trying something new. That might live in this other type of change. Now, disruptions can feel like they came out of nowhere, that there was no evidence that they were in the midst. But the truth is there are ways to recognize early indications of change. And in fact, a lot of the work that I do as a researcher at Institute for the Future is to be sensing and scanning for those early disruptions to our healthcare delivery system. We've been called ants, the researchers at the Institute, because we're out there with our feelers trying to scan and sense early indications of change across many domains. And it was in that scanning that I ran into a blog post that had been written by Susanna Fox. Susanna had attended a talk that Dr. Clayton Christensen had given on how people think. And in this talk, Christensen says, watch out for false boundaries. Now, he uses an education example to unpack his notion of false boundaries. He says, what if universities had to respond to a situation where there was no boundary, no difference between undergrad education and the working world? What would they do differently? So, of course, Christensen's idea of false boundaries got Susanna, and then eventually me, thinking about false boundaries in health and healthcare. But I think before we dive into the falseness or the veracity of certain boundaries, let's just take a moment to consider the role, the critical role that boundaries play in healthcare. First and foremost, boundaries save lives. They ensure patient and product safety. And boundaries protect our personal health information. And then by the way they limit roles, by the way they clarify power, and by the way they organize resources, primarily financial, boundaries can also improve our efficiencies and our scale. And at times, they can contribute to cost savings. But for every benefit that a boundary might offer, I think everyone in this room could argue there's a flip. For example, that same boundary that's protecting our lives and ensuring product and patient safety, that may also be contributing to the slower pace of innovation in health and healthcare. And I don't need to describe the second boundary in much detail. The same boundary that's protecting our personal health information is also challenging the ability for health information to flow and for interoperability to take hold in healthcare like it has in other industries. And then finally, that same sort of standardizing of care and organizing of resources that boundaries has created for us may be, in fact, what's detracting from the patient experience. So I suppose the argument I'm making about false boundaries here is not so much about whether they're false or whether they're true, but how useful, what's the utility of the boundaries we have in place if those boundaries were designed to form a model of care that was more provider-centric and hospital-centric than the way we want to go. Because here's the thing, boundaries fortify and support systems and models. So if we have in place boundaries that are supporting and fortifying models that are hospital-centric and provider-centric, well then the boundaries we have in place are actually counter-trend to everything that's being talked about today, everything that was talked about yesterday, and really everything that's been being talked about in the industry for the last 10 years. We talk about legacy systems. I think we need to talk about legacy boundaries. Because these boundaries that sort of structure how we deliver and organize care, they create path dependencies. And we get stuck in those path dependencies. And those path dependencies make it difficult for innovations to scale. Innovations like Oscar, or innovations like all the sort of experimentation happening in the maker movement. It's hard for us to take new ideas or take new services and find a way to place them if they don't fit in one boundary. Look, we know where change is needed. We know there are false boundaries between health and healthcare, between a patient and a person, between mental health and physical health. But until we start redrawing these boundaries and erasing ones that are no longer useful, it's going to be that much harder to systematically act on what we know. So I'm not a force for change, I'm just a researcher. So the force for change that I'm going to offer to this conversation are those who are not subscribing to these legacy boundaries. The force for change I'm looking at are those who recognize the boundaries that are in place and, quite frankly, are ignoring them. And so I'm going to spend the rest of my talk unpacking one of these forces for change. And to do that, I first need to set up the false boundary. And that's the boundary that exists between correctional health and community health. You see, it's not just that we have a different healthcare delivery system for people who are in prison. It's that we don't even count them in our public health numbers. When you hear about those staggering rates of mental health issues in prison or tuberculosis or chronic conditions in prison populations, those are not in our public health counts. We don't see prisoners as part of our communities. We don't see them as consumers of our healthcare services. We don't see them in our patient populations. But here's the thing. 80% of people who are in prison today have a medical condition that warrants health care. 85% are uninsured or without financial resources for health care. And here's the big kicker. 95% of people who are in prison today and who are in prison tomorrow will eventually be released from the correctional facility that they're in. On the aggregate, we're talking about 10,000 people a day arriving back into communities with this type of healthcare need. Annually, we're looking at 650,000 former inmates being released every year as we move forward. So, there's other things to consider with prisoners. And that is just like that demographic trend line that we're all experiencing outside of institutions, which is our aging population, same thing can be said for the prison population. Between 1999 and 2013, the number of state and federal prisoners aged 55 and older has increased by 234%. We went from having about 43,000 prisoners over the age of 55 to today we're closer to 145,000. Women are making up an increasingly larger percentage of our prison population. There are 832% more women in prison today than in 1977. Now, women, as we all know, have very different needs when it comes to health services. 75% of women in prison today are domestic violence survivors, and up to 10% of them entered prison pregnant. Finally, some experts say that the most dangerous health risk for prisoners is being released from prison because they are 12 times more likely to die in the first 2 weeks after they get out. A lot of this can be explained by drug overdoses and homicides, but other contributors include lack of medication and suicide. So if I've sold you on the false boundary, the boundary that exists between correctional health and community health, then let's start to talk about some of these forces for change that, like I said, are ignoring the boundary, and they're carving out new paths, making it easier for the rest of us to follow suit. And one of them that I'll highlight is called Transitions Clinics. It's a network of 14 clinics across the nation that are providing a medical home for former inmates as they transition from prison into our healthcare system. They tend to be those who have chronic diseases that need consistent management. Now, the Transitions Clinics relies on community health workers. And their community health workers do all the same things that the promotoras and the community health workers and lots of very effective programs across the US do. They help with self-management, they help with making appointments, they help them sort of navigate a healthcare system that they have not been exposed to, some of them in 20 years or more. But as you all know, community health workers have to be culturally competent, right? That's the lingo, that's what we like to talk about. So in this case, these community health workers, they're competent in the culture of prison and the culture of reentry. So this Force for Change Transition Clinic Network is part of that transformative future because they're changing the experience of care. Imagine going from this is what you're used to as a care experience, getting your medication, well, locked to a wall with an armed correctional officer in front of you, to care that ends with a hug. I want to make one more point about this boundary between correctional health and community health. And that is, it's not just that we don't count inmates as part of our patient populations or in part of our public health numbers. It's that we don't see inmates as part of our communities. There's two researchers who have looked into prison health deeply, or sort of the geography of prison, Laura Kergman and Eric Cadora, and they make this statement. They say this is problematic because prisons and jails form the distant ecostructure of many American cities. So if we're not considering them part of our communities, if we're not taking prison health or reentry health as part of our obligation in population health management or in care delivery or in community health services, then we're missing a critical piece of our communities. And Laura Kergman and Eric Cadora have actually looked into the geography of incarceration, right? They've sort of moved the conversation away from just mapping out crime rates to saying, let's map out exactly where people reside before they go to prison. And they've been doing this for over a decade, so some of you may be familiar with their work at the Justice Mapping Center. But essentially what they tried to do is say, can we take these big totals of money that we all know we spend in keeping people in prison and start to bring it back to the neighborhoods and see what it looks like. So for example, they looked at in 2003, they looked at the Bronx in New York. And they said, okay, the Bronx spends about $238 million, we collectively spend about $238 million to imprison people who reside in the Bronx. But they said, but you can go even deeper. You can go more high res and go down those numbers some more. And they said, actually, if you look at one city block, or in this case, one public housing development, you can say, we spend $570,000 a year, this was in 2003, to imprison people who live in that one public housing building. Imagine if we took that money and invested in the built, social, and ambient environment of people in that neighborhood. Imagine if we thought differently about where we spend the money and how we spend it. So like I said, they've been doing that work for about a decade. And so they've already seen tremendous change in how people talk about reentry employment. Policymakers talking about the geography of incarceration, the $1 million blocks that they identified all over the country caught on and changed the discourse when it came to reemployment and sort of thinking about justice reinvestment acts and that sort of thing. But this is our call to action to think about reentry health. Because if you think back to those statistics, 80% need medical care, 85% are uninsured, and 95% are coming back, will come home to their communities and their neighborhoods. This is our time then to think about our policies, our plans, and our initiatives, our innovations when it comes to reentry health. It's not going to be easy work to do, and it's probably going to take some dismantling of existing false boundaries, but that kind of work is truly transformative futures work. Thanks.